Good afternoon, everybody, and welcome to the top paper presentations. I hope everyone enjoyed the previous session that we had with the presidents. That was really pretty special. Anyway, we're going to try to stay on schedule. You have 7 minutes to present your abstract and a minute for us to maybe ask a question or someone from the audience to ask a question. I'm working with Professor Suter from Switzerland, and someone who's very experienced with these types of sessions, so it should run very smoothly. Anyway, we'd like to get the first speaker up, Professor Peterle. He's already there. And the paper is Outcomes Beyond 10 Years of Laparoscopic Roux-en-Y Gastric Bypass versus Laparoscopic Sleeve Gastrectomy for Obesity, Weight Loss, Comorbidities, and
Reoperation of the IFSO trial. It was a too long title. Didn't stay within the limit. Thank you, Scott. Good afternoon. These are my disclosures. They don't interfere with this presentation. The IFSO trial was a comparative trial involving 4 centers in Switzerland. Primary endpoint was % excess BMI loss at 5 years, and we had a number of secondary endpoints that we have presented before. If we look at the flow chart of the whole trial, it took us a long time to recruit because people had the patients with obesity applying for bariatric surgery. They had a firm opinion what kind of a surgery they wanted to have at the time, so it took us quite some time to discuss it with the patient so that they accepted actually then to participate in a RCT. So within more than 4.5 years, we could recruit 225 patients, and at the end operated on 107 and 110 in each arm. And at 5 years, we had a follow-up rate of 95%. And unfortunately, one center did not accept to participate beyond, so we had a higher dropout rate than we usually have in our trials at 10 years, and we have only a follow-up rate at 10 years of 65%. If you look at the 5-year results at the time, because it was a comparative trial, and according to missing values in some of the time points, and the statistics applied made that the difference of 7% excess BMI loss between the bypass and the sleeve did not reach statistical significance after adjustment for multiple comparison. And we were not very happy about that. Together with Paulina Salminen, we merged our data and designed it new in terms of a superiority trial and kept the primary endpoint % excess BMI loss. And then by merging the data, we could show that the bypass was superior after 5 years in terms of excess BMI loss. And now the topic of this talk is to present the 10-year results. And the primary endpoint is again % excess BMI loss, and we had a number of secondary endpoints as depicted here. If we look at the intention to treat population, then each line represents one patient up to something more than 14 years follow-up. You could see that the sleeve had 61% excess BMI loss and the bypass 65%, but that was not significant. But if we take into consideration that we had to convert a large number of sleeve patients, in numbers, it was 34% of the sleeves needed conversion to a other procedure, whereas only 6% of the bypass patients needed a distalization to perform a hyperabsorptive procedure. And there it was always due to weight loss issues, and in the sleeve group, it was also due to GERD or both. And if you look at the protocol analysis, you can see that the ones that really remained as sleeves in this cohort, there was only 48 left, they had a excess BMI loss of 56% compared to the ones that still had their standard Roux-en-Y gastric bypass with 150 centimeter alimentary limb and 50 centimeter BP limb. they had excess BMI loss of 66%. And if you look at the Kaplan-Meier curves of when these events happened, you can see that the sleeves continued with longer follow-up, with the need to have to be converted into another procedure, whereas in the bypass group at a certain time you had a stable weight with the ones that they remained within their weight loss. So if we look in the future, we don't know what's going to happen if you have a longer follow-up. If you look at comorbidity resolution, that's again in the intention to treat analysis, so none of these differences in diabetes remission, always the dark color is remission and the lighter one is improvement, and worsening is gray. And so dyslipidemia and hypertension, there were no significant differences, but in the GERD, it did not reach significance, but of course there were still patients in there that were in the ITT population. But then if you look at de novo GERD from the patients that did not have GERD and baseline, it was significantly higher in the sleeve group compared to the bypass group. That was already the case at 5 years, but you can see that there are a number of some patients after bypass also experience reflux symptoms. De novo Barrett was not significantly different. That's not part of this randomized trial. That's another trial we did. Similar to the sleeve pass trial, it did not differ between the two operations if you take Barrett's as being intestinal metaplasia, not gastric metaplasia. In terms of complication, early on, we had some internal herniations in the early follow-up, and now at the long-term follow-up, we had reflux and suboptimal weight loss result that caused reoperation. So at the end, we had at 10 years and more, we had more reoperations in the sleeve group compared to the bypass group. And if you take the CCI, Comprehensive Complication Index, if you take all patients into account, the average is the same. And if you look at the ones that did have a complication, the burden of the complication was exactly the same for both patient groups. And if you look at the SM-Barry score, you've seen that maybe in the presidential address, taking into account weight loss, comorbidity remission, and complications. Again, taking the CCI, there was no significant difference between the two. So in summary, sleeve versus bypass, weight loss in the per protocol population, it was significantly better, 10 excess BMI point % difference. And the remission rate of dyslipidemia and type 2. At the end, actually, we have a 15-minute left. But anyway, so I'm come to the end. The safety, I'd say, sleeve is safer in the beginning, but in the long term, if you take the conversions into account, I think bypass has the better chance to have only one procedure necessary to reach the goal. And it's reversible, and again, the conversion risk is elevated. So I skipped that. And I just want to announce practical course in bariatric surgery in Davos. I invite you or your younger colleagues to come. And in 2027, you're warmly invited to come to Basel to the joint IFSO EC EASO Congress. Thank you.
Thank you very much. Do we have time for a question? Is there a question from anybody?
If I may ask a question, in which terms did the results of this study influence your practice?
Very much so. We started with 35% sleeves at the beginning of the SM-BOSS trial, and there were years we only had 9% sleeves, and now it's about 12 to 15%.
Thank you. If there's no other question, we'll move on to the next presentation by Dr. Olivaria. Simultaneous versus interval sleeve gastrectomy on patients requiring left ventricular assist device as a bridge to heart transplantation. 7 minutes.
Thank you for the opportunity to present. These are my disclosures. heart transplant has substantially improved outcomes of patients with end-stage heart failure. However, not all patients are ideal candidates for it. It is widely accepted that BMI of 35 or higher contraindicates heart transplant given an increased risk in postoperative complications. The left ventricular assist device can be used as a bridge therapy for those patients with obesity and end-stage heart failure who are not candidates for heart transplant. However, even after LVAD placement, these patients are often unable to achieve adequate weight loss due to the significant immobility they have. They have a limited ability to exercise and often associated depression. And unfortunately, this results in many deaths even before the patient becomes eligible for transplant. Therefore, clinicians must consider alternatives such as bariatric surgery to improve the outcomes in these patients and optimize patient candidacy. We have previously shown promising results on performing sleeve gastrectomy after LVAD placement, yet the objective of this specific study we're presenting today is to assess the safety of simultaneous sleeve gastrectomy at the time of LVAD placement. Now, the rationale of this study radicates in the fact that any kind of surgery on these patients with LVAD possesses significant challenges, including the management of perioperative anticoagulation to balance the risks of bleeding and clotting. But also, LVAD devices are associated with several different complications, such as driveline infections, such as pump thrombosis, as well as significant healthcare utilization. Therefore, decreasing the time to transplant is, for this reason, very attractive on this patient population. So we conducted a single-center retrospective cohort study, and our inclusion criteria included adult patients with BMI greater than 35 who had end-stage heart failure and required an LVAD as a bridge to transplant. We excluded patients needing revisional procedures, patients with severe psychiatric conditions, as well as patients with cirrhosis and pregnancy. Now, for this study, our intervention group received a simultaneous LVAD and a sleeve, meaning both procedures were performed during the same anesthesia event, and our control was an interval sleeve gastrectomy, meaning the sleeve was performed at a later date after the LVAD implantation. Every patient underwent pretty much standardized preoperative evaluations, and the sleeves were performed in a usual, 4-port technique. We utilize serial 60-millimeter black loads with reinforcement over a 40 French sizing tube. Following the patient's extubations, we kept them on a clear liquid diet for 3 days and full liquids until 2 weeks post-operatively, and then they were on purees for 3 weeks before transitioning into solids. Now, the therapeutic anticoagulation was started between 12 to 24 hours of surgery, and of note, we did not perform any routine upper GIs after surgery. Our primary outcome was defined as sleeve-related complications up to 90 days of surgery, which was a composite outcome of postoperative bleeding, leaks, intra-abdominal abscesses, or death. Postoperative bleeding included both intraluminal GI bleeding determined by melena or hematemesis requiring an endoscopy, and also included extraluminal bleeding confirmed through a CT. Showing a hematoma or active bleeding. Then a staple line leak, we just defined it as extravasation of oral contrast on an upper GI series or a CT scan. And intra-abdominal abscess were defined by fluid collection seen also in CT scans in the setting of sepsis. These are all the secondary outcomes that we analyzed and included essentially the percentage of patients that achieved a BMI less than 35, the rate of transplantations, unplanned readmissions, unplanned reoperations, AKIs, length of stay after surgery, as well as excess and total body weight loss on their last follow-ups. These are the statistics that we utilized for our study, and we enrolled a total of 77 patients, of which 54 underwent a simultaneous LVAD sleeve, and 23 underwent an interval sleeve gastrectomy. The median time for an LVAD on those patients who had a sleeve gastrectomy in the interval group was about 18 months. Here are the baseline characteristics of our patients. Patients in the LVAD sleeve group were slightly older. Majority were males, and all patients had an ASA equal to or greater than 3. There were some important imbalances in their prevalence of hypertension, hyperlipidemia, and sleep apnea. The median BMI was 44 and was pretty much comparable between both groups. Now, 84% of our patients had heart failure secondary to non-ischemic cardiomyopathy. 90% of our patients had an ejection fraction under 25%, and nearly 1/3 had a pulmonary hypertension. In terms of our primary outcome, so although it was not statistically significant, the patients in the simultaneous LVAD sleeve had a clinically important lower rate of sleeve-related complications at 90 days post-op of 7.4% versus 17.4%. There were 3 upper GI bleedings in the simultaneous group and 4 in the interval group. And all of them were controlled endoscopically. None of them require any abdominal reoperations. There was 1 death in the simultaneous group that was unrelated to the sleeve gastrectomy, yet we still imputed for it in our analysis. Now, overall, 80% of the patients were able to achieve a BMI under 35. And when looking at the breakdown, pretty much both groups had similar rates of BMI under 35, respectively. It was 81 and 78%. Now, overall, 29% of the patients were transplanted. 3% had cardiac recovery, and 5% died. The rest are still pending transplantation. And there was a higher proportion of patients in the interval group who underwent transplant, yet they were also at higher risk of death. Now, for those who underwent transplant, the overall time to transplant was about 32 months, and patients in the simultaneous group had a shorter time to transplant. The simultaneous group had a lower rate of transfusions at the expense of a higher AKI rate, yet they had similar rates in readmissions, reoperations, length of stay, excess, and total body weight loss. Of note, majority of the perioperative complications were actually related to the LVAD sleeve and not directly related to the sleeve. Directly related to the sleeve, but more so of the LVAD placement. There are some limitations to our study. There's a procedural trend. Most of the interval sleeve gastrectomies were performed initially during the few early years, but then more and more simultaneous procedures were done at later years, which of course introduces the potential bias of creating imbalances in between groups, especially for follow-up. So that can explain why more patients in the interval group had more transplantations. And also, despite that, to our knowledge, this is the largest series in this topic, it's still kind of a small sample size. Perfect. Yeah, in conclusion, we believe that a sleeve gastrectomy increases the patient candidacy for transplantation, and simultaneous LVAD sleeve, it's definitely safe in this patient population.
IFSO guidelines. This is one of the categories that we were able to demonstrate that surgery was superior to non-surgery. You have time for a question?
I saw that you were giving these patients a very long time just liquids. Is it this a normal protocol for your sleep gastrectomy patients, or is it special to that study?
Well, I gotta say, it's actually standard in our institution to have them at least on 3 days of clear and a full 2 weeks of full liquid diet. So it's not necessary. We're not necessarily changing our practice for this specific patient population. It's our standardized practice in the bariatric patients overall.
Thank you very much. Nice paper. I'd like to invite the next paper, Dr. Stephen Axner. Midterm results of a randomized clinical trial, single anastomosis duodenal-ileal bypass versus biliopancreatic diversion with duodenal switch.
Ladies and gentlemen, good afternoon. My name is Stefan Axel from the Bariatric Center at Torsby Hospital in Sweden. And even on the behalf of my co-authors, I'd like to thank for the opportunity to present to you these midterm results of our randomized trial, single anastomosis duodenal ileal bypass, SADI, versus bilipancreatic diversion with duodenal switch, the BPDS procedure. SADI definitely simplifies the complexity of the BPDS procedure, and by eliminating the ileoanastomosis, we can reduce surgical time and hopefully complications while maintaining efficacy. This randomized clinical trial aimed at comparison of outcomes regarding weight loss, effects on associated medical diseases, and nutritional status. And to our knowledge, it's the first randomized trial covering this topic. We included patients with a BMI over 45 at the time of referral to our institution. The protocol was approved by the Regional Ethics Committee, and the study was registered at Clinical Trials. Prior studies on SADI had shown an excess weight loss after 2 years of more than 100%. Quite impressive numbers. In our own institution, we had done BPDDS, and after 2 years, our patients lost 89% of the excess weight. And assuming a similar standard deviation, a sample size of 56 was needed to reach 90% power with a significance level of 0.05 to prove the superiority of the SADI procedure. 63 patients were assessed for eligibility, 3 were excluded as they refused to participate. They chose specifically one of the procedures, and 60 patients were randomized. Patients were assigned to undergo one of the two procedures using sequentially numbered sealed envelopes opened after trocar placement. And 29 patients received the SADI procedure and 27 the BPDDS. Despite the COVID-19 pandemic, only 1 patient was lost to follow-up after 3 years. 5 patients discontinued the intervention, and 2 of them were in the BPDS group. And this was corrective surgery due to serious malnutrition. Following the intention to treat principle, these patients were retained within their group, so their results are included in this analysis. No significant differences were found in the preoperative data regarding age, sex distribution, BMI, and comorbidities. So what happened after 3 years? After 3 years, BPDS patients had a higher excess weight loss and better total weight loss compared to the SADI patients. However, these differences were not significant. And even the complete resolution of associated medical diseases was equal. We could not see any difference between the 2 groups. And when analyzing metabolic parameters, no differences were found in the improvement of HbA1c, fasting glucose ratio, LDL, HDL, and triglyceride. But the levels of vitamin D and A, they differed significantly after 3 years. However, it seems more important to analyze the ratio of patients fulfilling criteria for malnutrition or hyponutrition. And as you can see, none of the BPDS patients had an albumin beneath the level of 36. But please keep in mind, already 2 patients had undergone corrective surgery at that point. Significantly more patients after BPDDS had vitamin A level, E, and D under the cutoff value. So after 3 years, we can conclude that both SADI and BPDS, they result in comparable weight loss outcomes. And the impact on related medical diseases is equal. However, patients undergoing BPDDS are more likely to experience malabsorption or hyperabsorption of both macro and micronutrients. And this will lead to a higher incidence of nutritional deficiencies. And in our study, already 2 patients had to undergo corrective surgery after 3 years. Thank you very much.
Thank you very much. Nice presentation. If I saw correctly in your slides, you also had 2 patients converted to gastric bypass in the study group. Or
That's correct.
Am I wrong?
That's correct.
What was the reason?
In the SADI group, we had to convert them to gastric bypass, both due to a late sleeve leakage. Late. It was after 3 months, but we had to convert them.
That was the reason. Thank you. Moritz?
Thank you for this nice presentation. Can you provide us the limb lengths of both procedures that you have chosen?
Yes, we chose 250 in both. So 250 common channel in the SADI and 1 meter common channel and 150 in the BPDDS. So we kept to the limb length that were published early 2013-15 by Sanchez Penalty.
What would you hypothesize is the explanation of the higher rate of malnutrition based on the low albumin and the sated group?
Sorry?
But what would you hypothesize is the potential explanation of the higher rate of malnutrition in the sated group based on the albumin?
Oh, actually, it's a little tiny hospital, so I know each and every patient. One of them had undergone breast surgery a couple of weeks earlier, yeah, and the other one was ill in the flu, something like that. So even these values are not. I don't think that they are related to the SADI, to be honest.
Last question. Which procedure will you choose for the next patient? If you had to choose based on your results?
We're not doing the BPDS anymore, so we're only doing SADI, but we're doing it staged, always now, which is even a consequence of the sleeve leakages we have seen.
In every patient or in selected patients?
In
Staged in all the patients?
In selected patients.
In selected
patients. Not everybody is a candidate for SADI.
All right, thank you very much. Nice
Thank
paper.
you. So we'll move on to the next presentation by Daniel Moritz Felsenreich from Austria, Vienna. Esophageal function, acid and non-acid reflux after 1 anastomosis gastric bypass, manometry, impedance, 24-hour pH-metry, and gastroscopy. Please, Moritz.
Thank you for the introduction, the audience, dear chairman. Yeah, we'll speak about functional testing after OHEP. For this study, I have also received a grant. This is our case mix, so we're doing several types of bariatric procedures, as you see here. OHEP is, let's say, the largest group here with 29%, but we are doing also several types of other procedures. And worldwide, it's the 3rd most common procedure with 7.6% OHEP. So this is the surgical technique. We are performing a long and narrow pouch with a linear 30 millimeter gastrojejunostomy, and then the biliopancreatic limb of 150 centimeters, sometimes 175. We are always also performing
these anti-reflux sutures that are introduced by Carbajo in 2004, and then a single knot anti-kinking suture. And in some patients that are having a hiatal hernia, we are also performing a hyatoplasty. So if you speak about reflux or biliary reflux after OHP, there are several studies that are claiming that it's not a big issue. They are published some several years ago between 0.4 and 2%. But if you look to the more recent studies with an also long follow-up, you see here that the conversion rate seems to be a little bit higher due to reflux, 7.6% here. And in our own series, we have 4.1%. And that's why we performed the study. This was published about 2 years ago with functional testing on patients with OHP. And we are testing all these patients before the operation. So we're having pre-operative results of 24-hour pH-metry, manometry, and gastroscopy. And we invited them to the study for study reasons after that to measure them again. And for this publication, we had 20 patients, and we were now able to increase it to 50. What is the problem with these examinations? Unfortunately, it's very uncomfortable for these patients to have, if they're feeling good, some tube in their nose for 24 hours, having this measurement. That's why the numbers are so low. But I think the results are not bad. So this is the examinations that we are doing pre and post-operative. We had a mean follow-up of 4.1 years. The minimal follow-up was 1 year. All these 50 patients that we have now included in this study had no reflux at the time of the surgery. This is an indication for OHB in our center. So if some patients would suffer from reflux, we would immediately go for Roux-en-Waal bypass. That's why they don't have reflux before the operation. This was the history of weight in these patients. So the lowest post-operative weight they were able to reach was not bad, with a total weight loss and excess weight loss of 40 and over 90. And this was at the end of the follow-up after 4.1 years, still good weight loss results. But let's come to the more interesting results. This is the manometry, so the lower esophageal sphincter pressure from pre-operative to post-operative, not really changed. I think this is a sign of a good surgical quality, so we haven't harmed the lower esophageal sphincter. Let's come to the 24-hour pH-metry. The total number of refluxes, as you see here, has not significant change, just slightly increased. These are the number of refluxes in 24 hours. But if you look to the quality of the refluxes, you see here that the non-acid refluxes, so the biliary refluxes, they nearly tripled, significant, and the acid refluxes decreased from 27 to only 10 in 24 hours. Also, the Demisto score you see here decreased, and the acid exposure time of the esophagus. Why? Because, of course, this is mainly based on the acid reflux. These are the results of the gastroscopy. We had them from before and then 4.1 years after that. We see here we had in a certain amount of patients some anastomositis, anastomotic ulcers, also esophagitis, even in asymptomatic patients. And this was also confirmed in the pathological results of the biopsies in these patients. Bile in the pouch in nearly 50% of our patients. Just to complete the overview on this series in terms of remission of obesity-related complications, we had quite good results for diabetes, hypertension, good remission rates here, also sleep apnea, hyperlipidemia. Just GERD was a little bit increasing from none before the operation to 12% 4 years after. So how we are managing patients with reflux or biliary reflux after OHP? What we are trying is symptomatic therapy first, double dose PPI, ursodeoxycholic acid, no smoking, no alcohol, and also some dietological re-evaluation to avoid reflux-promoting eating habits like eating too late. In terms of diagnosis, we are doing a gastroscopy plus biopsies. We are looking for signs for reflux, esophagitis, etc. Sometimes we also do a 3D volumetry to see if the pouch is migrated to the thorax region. You can see that very good if there are staple lines above or below the diaphragm. And in some patients also manometry and 24-hour pH-metry before we are planning an operation if we see if the lower esophageal sphincter pressure has a problem, and to distinguish between acid and non-acid reflux. In terms of reoperation, if it comes to that, I think it has really proven that root-and gastric bypass seems the way to go. Hytoplasty if needed, if there is some pouch migration. But I think maybe the most important message here is that you should always look for some kind of obstruction in the common limb, some kinking, adhesion, or Peterson space hernia. In some of these patients that we had converted due to biliary reflux to root-and gastric bypass, we saw that there was an adhesion, there was some kind of stenosis in the common limb, and therefore the bile was not going down to the colon, but up to the esophagus. So to conclude, we had very good outcomes regarding weight loss and remission of obesity-related complications 4 years after. We saw a decreasing acid reflux, but on the cost of an increasing non-acid reflux. And a little bit concerning also the suspicious finding in the gastroscopy, like esophagitis, pouchitis, anastomotic ulcers, also in some of the asymptomatic patients. Thank you for your attention. This is the research group in Vienna, and next year we have the IFSO European Chapter Congress in Naples, and I hope you will all come there for good sightseeing and also scientific program.
Thank you very much. The paper is open for questions. Anybody have any questions?
Thank you, Moritz, for the nice presentation. I was wondering, if you convert to room-wide bypass, how much limb do you add to the existing one anastomosis that you've done before?
So if we convert them, we leave this 150 centimeter, and then we add another 70 to 80 centimeters of alimentary limb before we do the tracheostomy.
Yeah, exactly. Because if you choose too short a limb, then you still have the biliary reflux.
Yeah. I think 70 centimeter, everything below 50 might be too short. Yeah.
But you keep the same gastric pouch. You don't trim the pouch. Because you end up with a huge gastric pouch with a lot of acid and no bile to counteract.
I mean, it depends, yeah. If we see, for example, in the 3D volumetry that the pouch is massively dilated, yeah, we would perform some kind of pouch resizing in the same situation. But normally, if the pouch is quite good, which was the case in most of these conversions, we are just going for adding the tracheostomy.
Thank you. I also saw in your slide that you had 3 cases of Barrett's.
Oh, yeah.
You didn't mention it.
I haven't mentioned it because Barrett's is such a huge topic to discuss, and the 6 minutes is a little bit less of time. But yeah, also these patients don't had Barrett esophagus before the operations. This is a finding. I wouldn't stress it too much here because it's a very small series. But from the criteria, because there's always also some discussion, I have spoken with our pathologists. So for our Barrett's diagnosis, we need intestinal metaplasia, we need goblet cells, and also, and this is maybe the most important, a visual column line esophagus. So it's a combined diagnosis of pathology and what the endoscopist sees. Yeah. So if you just take them biopsies from a normal line, this is not a Barrett esophagus, but in these 3 cases, this was the case. Yeah.
Thank you. Last question, please.
Carmen Maia from Portugal. Really nice job. Congratulations. My question is, you are doing one anastomosis in asymptomatic patients, and you have seen 16% of ulcers, anastomotic ulcers.
Yeah.
I suppose you in Roux-en-Y bypass, you have much less ulcers. So how do you justify to continue doing one anastomosis if you have an asymptomatic patient and you find these ulcers and inflammation in the postoperative period of these patients?
Yeah, thank you for this question. I think all of these procedures have advantages and disadvantages, yeah, and I think also the Roux-en-Y bypass has some disadvantages. As we heard yesterday, for example, that the risk of dumping on the other side is maybe a little bit higher. The advantage of OHEB is that we had very good results for the weight loss, for the remission rates. We also have a short operation time, which gives us the possibility to treat more patients. But of course, we have now some ulcers in asymptomatic patients. We haven't known that before. And this is something that we have to think about in the future, yeah? If we have to maybe decrease this rate a little bit, yeah?
All right, thank you very much. The next paper is indications and outcomes of laparoscopic versus robotic conversional bariatric surgery, an MBSA QUIP study, and it'll be given by Dr. Juan Barajas Gamboa.
Hello. Thank you very much for the honor of the podium. Change of speaker, so I'm going to be giving this talk because Juan Pablo unfortunately had to fly out. So these are my disclosures. None of them are relevant for this talk. And the objective of this study was to compare the indications and the outcomes of conversional bariatric surgery using laparoscopic techniques versus robotic techniques. And what we did is we extracted data from the MSQIP from 2020 and 2022, and we looked at 30-day serious complications and mortality. So when you look at the demographics of this large data set, there were 72,000 patients, 75.4% were laparoscopic, the rest were robotic, and even though there were many statistical differences, I don't think that any of these were clinically significant. Specifically, when you look at the BMI for the laparoscopic group was 41, and the BMI for the robotic group was 41.5, and despite the statistical difference, I don't think that this really plays any significant clinical role. We did see a higher incidence of reflux in the robotic group, about an 8% difference between the two. In terms of the indications for surgery, we found that the number one indication for conversional surgery was reflux, which was listed in 26.8% of the patients. All of these patients are undergoing conversion for reflux. 69.6% were done laparoscopic. The second indication was weight recurrence in about 24.7% of the patients. Again, the vast majority done laparoscopic, and same thing for suboptimal initial response after surgery of 74.6 laparoscopic versus 25.4 robotic. The most common procedure that we saw listed was conversion of sleeve gastrectomy to Roux-en-Y gastric bypass. 37.9% of the patients in this cohort had this operation, and again, the vast majority done laparoscopic. The second most common indication was conversion of band to sleeve gastrectomy in one stage in 16.2% of the patients. And then you can see kind of a hodgepodge of other conversions, sleeve to SADI, sleeve to biliopancreatic diversion, same for band removal to gastric bypass, and a very small percent of VBG conversions. In terms of the outcomes, we did see a significant difference between the groups, mainly with operative time, with the robotic group taking on average 43.7 minutes longer for the same operation. There was less bleeding in the robotic group of 1.4% versus 1.7%. Slightly higher readmission rate in the robotic group, 6.8% versus 5.5% for the laparoscopic group, and a slightly longer length of stay of 1.7 days in the robotic group versus 1.6 in the laparoscopic group. In terms of our logistic regression analysis, looking at risk factors for severe complications, which are listed here based on definition, we did find that hypoalbuminemia and a longer operative time was a significant risk factor for severe complications in both groups. So in conclusion, what we were able to extract from this data is that the use of robotic platforms is being seen in almost a quarter of conversional cases based on MBSA QIP data. And the use of the robotic platform is associated with a slightly lower risk of bleeding of 0.3%, significantly longer operative time of about 43.7 minutes, slightly higher readmission rate of about 1.3% difference between the two groups, and a slightly longer length of stay. Thank you very much.
Paper is open for discussion. Any question? What do you make out of this data?
Well, I mean, I think the main thing with the boom in robotic technology is that I think we need to evaluate the data, understand the data, and I think the discussion about value is very variable between practices. So as of now, I think the data favoring robotics is yet to be seen.
Yeah, you know, when you have a database like the MBS Equip, which is hundreds of thousands of patients, very, very small differences are statistically significant only because there's so many patients in it. So what do you make of, what was it, 1.3 versus 1.7%? That was readmissions. That was the difference. I mean, is that clinically relevant?
I mean, it is if it puts you above the threshold for your performance within MBS EQIP data. You know, in this case, you're talking about a 5.5 versus a 6.8. So, you know, in these large databases for something like readmission and the cost of care, I think it's a very difficult conversation to have, especially when you go into the deep challenges of understanding robotic finance, that we're going to be doing an operation that is going to be taking, you know, 43 minutes longer, and there's a 1.3% chances higher of a readmission, which is also going to result in additional costs to the hospital.
Good point.
Difficult to sell the robot with this kind of data.
You know, I'm not anti-robot. I love the robot. I think it's a great toy, but I think we have to be critical of the data.
I agree.
Yeah.
All right.
Okay,
No
thank
further
you.
questions. We'll move on.
Next paper by Yuntao Nie. Glucagon-like peptide-1 receptor agonist for the treatment of recurrent weight gain after bariatric surgery, a systematic review, and meta-analysis.
Thank you very much. Hello, everyone. I'm Dr. Yun Tao from China Japan Friendship Hospital, and today my topic is GLP-1 receptor agonist for the treatment of inadequate weight loss and weight regain after bariatric surgery, a systematic review and meta-analysis. I have no potential conflict of interest to report. Bariatric surgery is an effective treatment for obesity with a percentage total weight loss of 20% to 35%. However, 15 to 40% of patients experience inadequate weight loss or weight regain, leading to the recurrence of obesity-related comorbidities and psychological issues. Revisional surgery, although effective, increases the risk of complications. GLP-1 receptor agonists and GIP, GLP-1 receptor agonists, have shown promise as adjunctive therapies after bariatric surgery. So, despite the potential, there is no systematic study summarizing the efficacy and safety of GLP-1 receptor agonist in treating inadequate weight loss and weight regain. So our meta-analysis tried to address this gap. Our study was registered on the Prospero platform. We conducted searches in Embase, Web of Science, Cochrane Library, and PubMed before March 2024. We included studies with more than 15 patients who underwent bariatric surgery, reporting inadequate weight loss and weight regain, and treated with GLP-1 receptor agonist for over 3 months. We used the Cochrane risk of bias tool for randomized control study and the Newcastle outward scale for non-randomized study. The primary outcome was weight loss outcomes reported as percentage TWL and absolute weight loss. Secondary outcomes included changes in biochemical markers, including lipid profiles, glycemic profiles, liver enzymes, and the incidence of adverse effects. A total of 19 studies were included in our analysis. Of these, 16 were retrospective cohort studies, 2 were prospective cohort studies, and 1 RCT. A total of 1,290 patients were experienced inadequate weight loss and weight regain and underwent GLP-1 receptor agonist treatment. The initial surgery included sleeve gastrectomy, proximal gastric bypass, anastomosis, gastric bypass, gastric banding, and biliopancreatic diversion. The definitions of inadequate weight loss and weight regain vary slightly, but most studies defined inadequate weight loss as percentage EWL less than 50% at 12 to 18 months post-surgery, and weight regain as 10 to 15% weight gain after reaching nadir weight. The average age was 46 years, with 82% female patients. The mean pre-operative BMI was 46.3. The lowest post-operative BMI was 31.1, and BMI before starting GLP-1 receptor agonist treatment was 37.2. Most patients started GLP-1 receptor agonist treatment before more than 5 years after surgery. Liraglutide was studied in 11 studies, semaglutide in 5, tirzepatide in 1, and 2 studies analyzed mixed GLP-1 receptor agonist results. So let's look at the primary outcome. The pooled percentage TWL with GLP-1 receptor agonist was 10.03%, with liraglutide achieving 9.24%, semaglutide 11.38%, and tirzepatide 15.5%. The pooled absolute weight loss was 9.79 kilogram, with liraglutide achieving 8.56 kilogram, semaglutide 11.62 kilogram, and tirzepatide 12.6 kilogram. For patients using liraglutide for less than 6 months, the percentage TWL was 7.65%, and the weight loss was 7.47 kilogram. For 6 to 12 months, the percentage TWL was 10.22%, and the weight loss was 9.3 kilogram. For more than 12 months, the percentage TWL was 10.8%, and the weight loss was 10.04 kilogram. For semaglutide, the percentage TWL at 6 months was 10.18%, with a weight loss of 9.43 kilogram. At 12 months, the percentage TWL increased to 13.15%, and the weight loss to 14.68 kilogram. GLP-1 receptor agonist treatment lead to significant reductions in triglycerides, total cholesterol, LDL-C, glycated hemoglobin, and ALT. Changes in HDL-C, CRP, and AST were not significant. Nausea was the most common adverse event, occurring in 23% of patients, followed by vomiting 6%, diarrhea 6%, constipation 10%, headache 6%, fatigue 8%, abdominal pain 2%, and bloating 2%. Both the funnel plot and Eagers test indicated no publication bias. So to draw the conclusion, patients experiencing inadequate weight loss and weight regain after bariatric surgery who were treated with GLP-1 receptor agonists achieved a pooled weight loss of 9.79 kilograms and 10.003% TWL. Tirzepatide showed the greatest efficacy, followed by semaglutide and then liraglutide. GLP-1 receptor agonists have been shown to reduce lipid profiles, glycemic profiles, and transaminase levels in patients with inadequate weight loss or weight regain after bariatric surgery. Adverse events occurring with GLP-1 receptor agonist treatment were predominantly gastrointestinal, with the highest incidence of nausea. However, the incidence of these adverse effects remains within an acceptable range. Future research should standardize the definition of inadequate weight loss and weight regain after bariatric surgery to accurately determine the true efficacy of GLP-1 receptor agonists. Thank you to all the investigators, and thank you very much. Thank you. Yeah.
Thank you very much. As you know, these definitions have been set by IFSO at the beginning of the year, with too much recurrent weight gain, meaning more than 30% of the weight loss.
Yeah.
I know in all the studies this has been described in various ways. I urge everyone in the future to use the new denominations and definitions so that we can compare studies between each other.
Yeah.
Any questions from the floor about this study?
I have a question for you, and I apologize if you said it and I missed it. Did you start the medication at a specific interval after surgery, or was it when patients came to the office putting weight on? When did you decide to start the medication? What was?
In my center, we start the GLP-1 receptor agonist maybe for some larger patients, some BMI larger than 50. We use them 3 months or 6 months after surgery.
So everybody BMI over 50
Yeah, we combine.
When they hit, so you waited 6 months and started it?
Yeah.
Any other
Is,
questions?
are these medications reimbursed in your country?
Yeah. Maybe we can use liraglutide and semaglutide in my country
But they're paid for by insurance?
by insurance. Yeah.
You're lucky.
If at 6 months a patient was actually doing well and losing more weight, would you then have started the medication?
It is depends on the percentage of TWL after the surgery. Maybe more than 20 or 25%, we will not use the GLP-1 receptor agonist. Yeah.
Okay, thank you.
Yeah. Thank you
All
very
right,
much.
the next paper.
Thank you.
Intersurgeon variability in metabolic and bariatric surgery in the Netherlands, a multi-level analysis, Dr. Ronald Lem.
Thank you. As earlier today, I speak on behalf of Floris Bruinsma, our PhD candidate. He is a young father. He couldn't make it to Australia, unfortunately, for happy reasons. I have nothing to disclose on his behalf. So what are the influences, the chance of a successful outcome? Much research has been done and various risk factors have been identified, such as the presence of comorbidities, smoking, BMI, age, sex, and socioeconomic status, to name a few. But how are all these risk factors related? These are all patient-related risk factors. However, differences in outcome could also originate at the quality of healthcare delivery by the surgeon or by the hospital. Therefore, it is important to investigate those factors as well. For that reason, the aim of our study was to investigate where the largest part of the variation in outcomes originates, at the hospital level, at the surgeon level, or at the patient level. The hospital level covers all in-hospital care except for the care delivered by the surgeon, him or herself, meaning that it covers perioperative care by all other caregivers such as nurses, residents, and anesthesiologists. It also covers, for example, treatment protocols which are standardized throughout the whole hospital. Among the outcomes were severe postoperative complications. In Holland, we register within 30 days, reoperation, prolonged length of stay, readmissions, and textbook outcome, which is a composite outcome for having no postoperative complications, no prolonged length of stay, and no readmission. Patients were selected from the Dutch Audit for the Treatment of Obesity, which is a mandatory quality registry for metabolic bariatric surgery in the Netherlands, collecting patient data from 2015. Patients were included if they received primary surgery between 2020 and 2023 and were excluded if they missed any of the relevant baseline characteristics. To be able to determine the influence of each level on the outcomes, first, relevant patient characteristics influencing the outcome were determined. Second, a multi-level model was created, including hospital and surgeon, as the higher levels and the relevant patient characteristics were entered in a model. Thereafter, the variance for each of the three levels could be determined and a proportion of the variance ascribed to each level was calculated. Last, the interclass correlation coefficient was determined for the surgeon and the hospital. We identified 30,000 patients with complete baseline characteristics who were operated by 95 surgeons from 19 different hospitals in the Netherlands. These are the results. We found that surgeon factors, depicted here in orange, attributed to 90% of the explained variance for severe postoperative complications, and this was 38% for reoperations. For the other outcomes, the surgeon explained just very little amounts of the variation. In all cases, the largest part of the explained variance was ascribed to the hospital level, indicating that if patient care should be further improved, it would be better to look at possibilities for improvement on the hospital level instead of the surgeon level. However, when putting the explained variance into the context of the total variance, we can see how much of the variation is actually explained by both levels. Here we see that for the outcome reoperation, the interclass correlation coefficient is 1.9 for surgeon and 3.0 for hospital, indicating that 95% of the variations is either originated in unmeasured risk factors or induced by chance. In all cases, the ICC was larger for the hospital level than the surgeon level. To conclude, we found that surgeon-related factors play some role in adverse events. However, hospital-related factors play a larger role. This means that perioperative care influences outcomes more than the surgeon's surgical skill. However, it must be kept in mind that the Dutch bariatric healthcare is centralized and each hospital needs to perform at least 200 metabolic surgeries per year and need to have a team of at least 2 dedicated surgeons. Therefore, our results might not be generalizable to other healthcare systems. I want to thank all the participating hospitals in the Netherlands in the Dutch audit for the treatment of obesity, and thank you for your attention.
All right, the paper is open for discussion, questions.
Now, your system mandates every center to do at least 200 cases a year. Is there a limit per surgeon?
No, it's an institutional level, so it is 200 procedures
So
per
within a
institution.
center, you could have a surgeon doing 180 cases and the other 20.
Yeah, that could be the case, and that was actually what we're investing in these studies, but it doesn't appear to influence the outcome.
How is this study going to affect work? Are you going to make changes? Are you going to do an analysis of all of the hospital-related involvement with the patient?
This, of course, is aggregated data from the Dutch National Registry. We do a yearly audit where all these kind of outliers are appreciated. And if we see that a certain hospital is an outlier on the downside of the scale, then they will actually get an invitation to be audited.
Moritz?
Since when do we have the Dutch registry?
2015.
2015. And when you implemented that, you had to close some of your bariatric centers in the country, or not?
Yeah, hospitals had 2 years' time to reach the level of 200 procedures per year. If you would start a new center, you will have 2 years' time to reach the dedicated levels. If you cannot reach it, you have to abandon the practice again. Yeah.
Any other question? Then thank you.
Thank you.
Next paper by Megan Grimlington. 10-year results of a randomized controlled trial comparing banded Roux-en-Y gastric bypass to sleeve gastrectomy for type 2 diabetes and weight loss. Please.
Kia ora everyone, my name is Megan Grimlington and I'm a General Surgical Fellow working at North Shore Hospital in Waitemata in Auckland, New Zealand. I am presenting the 10-year data of a randomised control trial carried out at North Shore Hospital comparing celastic ring laparoscopic Roux-en-Y gastric bypass with laparoscopic sleeve gastrectomy for type 2 diabetes remission and weight loss. I will start by presenting the trial protocol and briefly review the relevant 1, 5 and 7-year results. I will then present our 10-year findings. Here are my disclosures. We performed a single-centre, prospective, double-blind, randomised control trial at North Shore Hospital in Auckland, Aotearoa, New Zealand. It was double-blinded to assessor and patient for 5 years, and recruitment took place from September 2011 to October 2014. Selection criteria is summarised here. The primary outcome was to determine whether celastic ring laparoscopic Roux-en-Y gastric bypass was superior to laparoscopic sleeve gastrectomy in terms of diabetes remission at 5 years. I will refer to these procedures as bypass versus sleeve for the rest of this talk. There were a number of secondary outcomes which are listed above. The study was 80% powered to demonstrate diabetes remission at 5 years, requiring 53 patients per group to do so. Randomisation was computer-generated 1-to-1 and was stratified based on age, BMI, ethnicity, diabetes duration and requirement of insulin. 221 patients were eligible. After exclusions, 114 patients were randomised, with 58 in the sleeve group and 56 in the bypass group. On the day of surgery, random number codes were disclosed to the operating surgeon after anaesthetic induction in theatre, and patients had identical laparoscopic port site incisions. Patients either received a sleeve or a bypass. The sleeve was performed beginning 2 centimetres proximal to the pylorus with an Echelon Flex 45 stapler tight over a 36 French bougie and a selective omentopexy. The bypass was performed using a lesser curve pouch over a 32 French orogastric tube with a 50 centimetre BP limb and a 100 centimetre roux limb. A hand-sewn single-layer gastrojejunectomy was fashioned over the orogastric tube. A 6.5 centimetre celastic ring was secured 2 centimetres above the anastomosis. At 5 years, there were 98 patients with complete follow-up, with 2 lost to follow-up in each group. At 7 years, there were 89 patients with complete follow-up. 15 were lost to follow-up in the sleeve group and 4 in the bypass group. And at 10 years, there were 83 patients with complete follow-up. 13 lost to follow-up in the sleeve group and 5 in the bypass group. The baseline information was equivalent between the two groups as pictured. These are our publications to date, starting with the protocol, the 1-year results, the 5-year results, and the 7-year results. This is a summary of the results at 1, 5, and 7 years. Drawing your attention to the left side, this shows remission of type 2 diabetes as assessed by HbA1c levels. At 1 year, there was no difference between groups. However, at 5 and 7 years, a difference emerged in favour of the bypass. Looking at the right-hand side, this shows the mean percentage total excess weight loss. This was greater in the bypass group at 1, 5, and 7 years. The 10-year trial has the same objectives as previously mentioned. This trial is one of the longest-running RCTs, directly comparing these two operations, and the data we have collated is significant. At present, we have 1,144 patient years, with follow-up for 13 years for some patients, and this averages to 10 years per patient. 83 out of 102 remaining patients gives us a total follow-up rate of 81%. The original patient group continued their follow-up. Patients were seen face-to-face where possible, and we also accessed electronic health records, GP visits, and pharmacy dispensing data for results. Data from within a 6-month window before or after the 10-year date from surgery were included. These are our results. Diabetes remission was seen in 16.7% of patients after sleeve and 29.8% after bypass, with a p-value of 0.080. Percentage total body weight loss was greater after bypass when compared with sleeve, 27.2% versus 19.5%, with a p-value of 0.003. Complication rates, lipids, and deaths were not different between groups. 12 patients died by the 10-year follow-up, 4 in the bypass group and 8 in the sleeve group, and this was not significant between the two groups. We conducted a subgroup analysis on Māori and Pacific peoples as they appeared to have a lower rate of diabetes remission. In terms of pre-operative characteristics, they were relatively well matched in terms of procedure. 22.4% had a sleeve and 30.4% had a bypass. There was no difference in age between the two groups, and the percentages of Māori and Pacific patients compared with European and other at baseline is almost identical to the proportions followed up at 10 years, as you can see by the arrows. In terms of diabetes, the pre-operative HbA1c was worse for Māori and Pacific patients, 8.74 versus 7.65, with a p-value of 0.0002. Diabetes duration pre-surgery was longer, and there were more Māori and Pacific peoples on insulin pre-operatively, but this was not significant. In Māori and Pacific people, only 2 out of 22 had remission of diabetes, compared with 18 of 61 of the European and other group. This approached statistical significance with a p-value of 0.080. This graph shows the difference in percentage remission of diabetes in the sleeve versus the bypass group, with the top line showing a higher remission in the bypass group. This graph demonstrates the ongoing differences in HbA1c between the sleeve and the bypass. A lower HbA1c is consistently seen in the bypass group. And this graph shows the difference in percentage weight change in the sleeve group versus the bypass group. A greater weight loss can be seen in the bottom line in the bypass group. To summarise, at 10 years, the bypass was superior to the sleeve for percentage total body weight loss. Diabetes remission also appeared superior in the bypass group. Māori and Pacific peoples had worse outcomes. This group had a significantly higher HbA1c at baseline. Preoperatively, these patients had a longer duration of diabetes and a higher number were on insulin. This study adds to the growing body of evidence that confirms improved long-term persistent outcomes with bypass when compared with the sleeve. Thank you.
Is it your custom to put bands on all the bypasses?
It depends. So in the public hospital, it's surgeon dependent. For the purposes of this trial, we specifically put celestic rings on all patients, but it's surgeon dependent.
This is easy. Well, what would make you want to put bands on everybody when, there's already literature out there that the bypass is superior to the sleeve for patients for weight loss and improvement comorbids. So what was the rationale for only doing bands?
We believe that the celestic ring adds approximately 8 to 10 kgs more of weight loss, and I think that looking at the results of this study, it shows that weight loss persists over a really long period of time. So potentially the celestic ring provides that extra restriction which persists even when patients have their anastomosis dilating up.
And over the 10 years, how many bands had to be removed?
Only 5 out of 114 patients.
Yes.
Two very quick questions. First, sorry, all the sleeves had bands as well, is that correct?
No, the sleeves
Right,
do not.
so it's actually banded bypass versus unbanded sleeve.
Yeah.
That's the first thing. The second thing is that your total body weight loss figures for your sleeve gastrectomies are very low compared to the Australian Bariatric Surgery Registry results that we would expect to see. I noticed you did a differential on Maori Pacifica versus Pateca for diabetes, but not for weight loss. Can you speculate as to why your weight loss figures are so poor for sleeve compared to the registry data?
I think the main point of this patient population is that they are type 2 diabetics, so everybody was diabetic. And I think that there was very good weight loss initially amongst both groups, and over time they have gradually had weight loss in each group, but it is a very comorbid patient group, and often with poorly controlled diabetes. So I think that does also contribute to the weight regain when compared with obese patients without diabetes.
Ronald?
Congratulations on your nice study. Happy that it substantiates already existing evidence. I had the same concern about the ring augmentation. You say that it yields more weight loss, but if you look at your data, you see that over time, weight loss, even in a bypass group, diminishes slowly. But then the remission rate of diabetes is actually getting better over time. So there must be a weight-independent effect. What is your comment on that?
Well, going back to the slides, it was actually that the weight loss was still significant, but the diabetes remission became less significant at 10 years compared with 7 years. So some patients are getting their diabetes back, but the weight loss is still significant between the groups. So it was actually the other way around, I believe, yeah. Sorry, that's okay.
We have time for one last question.
Sorry. I did notice that the majority of the population was performed in a public hospital. And do you think public patients and their weight loss outcomes may not be able to match the predominantly private data that we have within Australia? Do you have a comment on that?
Yes, I think that's a really great comment. We do tend to operate on morbidly obese, comorbid, older patients in the public system, so quite naturally our data would not be as good as patients who are operated on in the private system. Yeah. But I do think that this study is really representative of large populations as a whole. Australia and New Zealand are quite comparable populations.
Thank you very much. Thank you. I'd like to introduce now the last presentation for the afternoon. It's the influence of the intestinal microbiota on the pathophysiology of non-alcoholic fatty liver disease study in patients with severe obesity. Dr. Luis Ocaña.
Thank you. Thank you very much. This is Dr. Ocaña from Malaga, Spain. We are talking about the influence of the intestinal microbiota on the pathophysiology of non-alcoholic liver disease, studying patients with severe obesity. This is the distribution. I have no conflict of interest. This is the distribution worldwide of MAFLD, North America, Europe, Middle East, also India and Australia. So this is a relation in two ways. People with this metabolic syndrome have a prediction of MAFLD, and vice versa is going to be the same. This is the natural history of MAFLD. If you see, it's a lot of years, but maybe you are thinking about this is an illness for elder people. This is wrong. Today we have people with 18 years old with this problem, and when they are 44 or 46, maybe they need a liver, but there is no liver for everybody. So this is the pathophysiology of MAFLD. These three things, metabolic syndrome, high intake of saturated fatty acids, and some kind of genetic predisposition, we can change this marvelous biopsy in this other with balloonization, necroinflammation because of this problem. The reason of this study is to add the good microbiota dysbiosis. It took, in my opinion, the principal role in this problem to go finally to this absolutely tremendous biopsy, the fibrosis and the cirrhosis. As you know, microbiota have an influence in obesity, dyslipidemia, type 2 diabetes, atherosclerosis, and also MAFLD. And what the meaning, the behavior of this microbiota, changing of the composition of the bile acids, the production of short-chain fatty acids, the promotion of some harmful product like ethanol. This is the main problem. As you know, we can produce endogenous ethanol. Not only the ethanol we're taking alcohol. This is the best, the principal reason for the alcoholic cirrhosis. But I'm talking about the endogenous ethanol product because of the microbiota. The other problem is the enterocyte barrier. These harmful products go to this barrier and destroy, and that's the reason they go inside the vessels. And the portal vein is like a big highway with two ways direction, going inside the liver without no problem, without no barrier, all these harmful products, and throw away the liver to the good axis liver to other parts of the body, the other products like bile acids changing and making some harmful relations in other parts of the body. Let me talk finally about the farsinoid receptor. This is so important because have a very important relation with the decreased lipogenesis, the decreased liberation of very low density lipoprotein. This is also destroyed because of the harmful products of the microbiota. This paper talk about how about the good microbiota signatures of MAFLD, just to increase abundance of Escherichia, Prevotella, and Streptococcus, and decrease abundance of Copococcus, Faecalibacterium, and Ruminococcus, and they are health promoters, so they are descending. This not only to increase the bad microbiota, but it's also to decrease the good microbiota. The aim of this study is to describe the composition and prediction function of the gut microbiota in patients with morbid obesity underlying bariatric surgery with some degrees of liver biopsy. This is a single center, and we exclude patients taking antibiotics, probiotics, and prebiotics, and also with inflammatory or any other infection or liver disease, or taking also ursodeoxycholic addicts previous week later. We make three groups because of the biopsy. The biopsy, we take three levels: liver steatosis, necroinflammatory activity, and also fibrosis, and we decide to make three groups. Patient of the control group without steatosis, without fibrosis, without necroinflammatory. Second group just with steatosis, grade plus or more than 1. And the third group, the more illnesses group, is patients with morbid obesity and steatosis grade plus 1 plus NASH, steatohepatitis with or not fibrosis. How about the results? We are, as I told you, 110 patients. 7% were female. That used to be normal in our group in bariatric surgery. The mean age is close to 47. And as you know, parameters like age, glucose level, insulin resistant, cholesterol, and triglycerides was significantly higher in steatosis plus NASH group than in the control group. There is no statistical significance in other variables like hydrocarbon and lipid metabolism, and also liver enzymes, as you know, is not a good, not invasive marker for practically for nothing. We are talking about the liver, except the hepatitis also. Well, this is the result. You see, this is the significance. And how about the microbiota? This is a more important thing. We make these 5 tests to see what. As you see, the dark one is the control group, the second one is the steatosis group, and the white one is the NASH plus steatosis with or not fibrosis group, the third group. The behavior is different. This is the result. When we study the gut microbiota composition and its predicted functional properties in MAFLD preparation, we see the group steatosis plus NASH was enriched in Enterobacteria family and Minococcus and Megasphaera genera. The control group was enriched in promoting healthy species, Egersalae and also Ruminococci family. There is no significant enrichment we observed in the steatosis group. So, in conclusion, what means all this change in the microbiota? Our findings show a patient with morbid obesity, steatosis, and NASH diagnosis worked by altered microbial pattern. An increase in Enterobacteria family, the third group, is an ethanol-promoting bacteria. And the depletion of Ruminococci family is a health-promoting bacteria, is bad for the patient. So MAFLD produce another harmful products, and the ethanol or succinato resulting in possible mechanisms for the pathogenesis in the MAFLD. How about the future perspectives? Well, we have to think about maybe we have new targets and new treatments. How about the role of non-unsurvivable antibiotics for treat this problem or include to improve the MAFLD? How to feed the microbiota, thinking in the species promoting liver changes, and finally, how to protect the enterocyte mucosa barrier and to avoid the circulation of harmful species through the portal vein inside the liver. I'm very proud all my team in Malaga, and let me invite you also to go to Venice, but next year, 2026, to Malaga in EC European Chapter Conference. Thank you very much.
Thank you very much. You showed very nicely an association between these bacteria and fatty liver disease and the more severe form of the disease. Do you have any hint to show causation? Are the bacteria responsible for this, or is the liver responsible for a different microbiota? Do you have any idea about this?
We have a short idea. I think we are starting. I think we are in a cave. We have maybe 2 kilometers of information, and I think we are in the top. We have to know so much about the relation between the liver and MAFLD and the microbiota. But something I am sure we are discovering another target, another way to treat our patient. I'm talking about antibiotics. A recent paper treating non-absorbable like rifampicin antibiotic, trying to change the bad evolution of MAFLD. So it means nothing. Maybe we have to look to other side, not only metformin, not only the classical treatment to improve MAFLD, but maybe other, thinking about the microbiota.
Thank you. Yes.
Hi, Ian Michelle from Melbourne. Really interesting, thank you. It seems that the microbiota change was in the patients who had steatohepatitis, but not in the patients with steatosis. So were there other markers of inflammation that were changed with this microbiota?
Mm-hmm. Yes, thank you for the question. There is no really big change in the patient without NASH. We saw change in the patient. Probably if because the patient with NASH destroy the barrier and they open the door for the harmful products go to the portal vein. It's like a big highway going everything inside with the good liver axis. The patient without steatosis, steatohepatitis, or non-fibrosis, I think the farsinoid receptor and any others in the enterocyte are better because they are not destroyed. So the closest door could be the reason for this problem.
Any other question from the floor? Then I think I'm happy to close this session. Thank you very much to all the speakers, all you who stayed till the end. I wish you a nice ending of the Congress and all of you a safe return back home. Thank you very much.
Mr. Crozier, work with you?